Skeletor! Stop!
Too late, fools! Now you have a choice. Save Castle Grayskull or try to save this woman from Dragosaur Isle.
Hi everyone, thanks for watching and welcome to Past Physiology review of Topic 4. This is the second video where we're covering from the synovial joint capsule layers through the pathologies. Right now we're looking at the bottom of the study guide posted for you on Brightspace and Portal. You should have already gone through the video on the different joint classifications. If you have not, I recommend you do that. If not now, later. But right now we're going to be looking at the synovial joint capsule. So I'm going to make this a little bit smaller. And we can look at a picture similar to something you'd see in Gray's. And we're looking at a simplified joint. This might be an interphalangeal joint because it's just two bones. If it were a knee, we would see a fibula in here. But what we've got is a synovial joint. The outside is going to be a fibrous membrane, also called a capsular ligament. Okay, it's a thick, somewhat protective layer that'll be continuous with the bone, with the periosteum of the bone, which we could see this little white lining around the bone. We'll call that periosteum. You would have Sharpie's fibers blending the periosteum into the fibrous membrane. The fibrous membrane is commonly called a capsular ligament in most of your classes, so the two are synonymous. Deeper, you'll have a synovial membrane, and this is where it gets a little more complex. It's the inside layer. It's going to cover anything that's not cartilage. And the synovial membrane will have two layers that comprise it. The outer layer of the synovial membrane is going to be this fibrous layer of the synovial membrane. Okay, so don't get confused with fibrous membrane. Okay, you have two membranes, fibrous membrane, which is the capsular ligament, and then you have a synovial membrane. The synovial membrane has two layers. It has an outer fibrous layer and an inner cellular layer. Okay, this is kind of the rule in all these things with two layers, like periosteum, etc. Outer layer is fibrous, inner layer is cellular. It kind of makes sense because the outer layer should be more protective to the external environment, thus it should be more fibrous, as opposed to a more naked inner layer that is just cells. So you need to know what is in the outer fibrous layer of the synovial membrane, and what it is will be fibers and things that make fibers. So collagen fibers and fibroblasts. Okay, so the fibrous layer has fibers and it needs to get more fibers. More fibers come from fibroblasts. So then the intercellular layer, okay, which is going to be kind of where I'm tracing right here, the intercellular layer of the synovial membrane of a synovial joint capsule. This intercellular layer will border the synovial cavity, which is shown yellow on this picture. Okay, this yellow is just all synovial fluid. It is the synovial cavity. The cellular layer will have blood vessels, some collagen holding a structure together, and synoviocytes. Sites always means cells, so these are cells involved with synovial fluid, okay, synovial joints. So the cellular layer has synoviocytes, and there are two types of synoviocytes. So you need to know the two different types of synoviocytes. They are arranged here from superficial to deep. This whole table is superficial to deep. The type B, this little arrow means above, okay, or more superficial. The more superficial type B synoviocytes are fibroblast-like or fibroblast-ic. You could say fibroblast-ish if you wanted to. Probably not on a test, but B for blastic, okay? B for blastic, B for blastic. They are synovial cells that produce hyaluronic acid. They are referred to as fibroblast-like because they are making long strands of something, okay? And that something is hyaluronic acid. Think back to when we, talked about ground substance. Hyaluronic acid is just a chain of sugar, but it is a super duper long chain of sugar. So that is the same shape, I guess, as a fiber. It really varies greatly from collagen fiber, but it's fibroblast-like because these type B synoviocytes are producing a long strand of something, but it's not actually fiber, it's hyaluronic acid. Because hyaluronic acid dominates synovial fluid and synovial joints, it's essential for binding up tons of water and providing a good lubricating medium for articulation. So the other type of synoviocyte is the type A. Type A is the deepest. The type A synoviocytes are macrophage-like. Now we've talked a little bit about macrophages in passing when we were talking about the osteoclasts, because they have the same origin, basically they come from monocytes. But a macrophage is an immune system cell. Okay, it's a little cell. It's a white blood cell that goes around gobbling up bacteria and debris in your tissues. Phagocytosis means eating. Okay, it basically means eating. All right, so phago means to eat, and cytosis refers to a cell. Okay, or cell eating, or eating cells. It's a cell that eats cells. Technically, it's a white blood cell that eats cells. So macrophage, you need to know what a macrophage is for this to make sense. Okay, a macrophage is a white blood cell that eats things that should not be in your body. So the type A synoviocyte acts like an immune system cell. It acts like a macrophage. It eats garbage in your synovial tissue. Okay, whatever is not supposed to be there, whether that be debris or bacteria, it performs the same functions as a macrophage. It performs phagocytosis. It's eating. Okay? So how are you going to remember that type A synoviocytes are macrophage-like? Well, if you ate something, that means it's a past tense of to eat. Okay? So when you see A, think ate. Okay? You ate bacteria, you ate debris, you ate something, you ate something, you performed phagocytosis. All right? If you have a better way to remember that, please indulge us in our group meetings, but that's how I do it. Type A for you ate something, and type B is blastic. Or if you just want to remember that one of these synoviocytes builds stuff, the other synoviocyte gets rid of stuff. If you know that B is the blastic builder synoviocyte, blast, build, okay? If you know that the type B synoviocyte is the builder blastic cell, then you know it's making something. You need to know it makes hyaluronic acid. You could get stumped if she offers you, distractors that it makes other things. You need to know that it is hyaluronic acid that is being made. But if you know one of these two, you can guess the other. Type B synoviocytes, I know those are the builders. So I know there's A and B, so obviously A must be the one that gets rid of stuff. But you need to be able to draw from your memory that phagocytosis is eating stuff, okay? So try to nail down both of those. So then the most central, I guess technically central, or the deepest layer of the synovial joint capsule is going to be the synovial cavity. And this is just a pocket of synovial fluid. Synovial fluid is a viscous, gel-like fluid that lubricates your joints, and it's comprised of hyaluronic acid and blood plasma. Blood plasma is basically liquid filtered out of your blood, so there's not going to be any red blood cells in there. It shouldn't be. It's just the liquid plasma part of your blood. So what does synovial fluid do? It lubricates, it cushions, it protects, and it provides nutrients for the articular cartilage because there's no direct vascular supply. So nutrients for articular cartilage via diffusion. Okay, any blood vessels anywhere around here, but you would find them in the cellular layer, okay, of the synovial membrane. Those blood vessels would diffuse nutrients into this fluid, which would feed this cartilage, and it would also remove waste from this area as well. So here's our picture. You could use it, you could use grays, you could look it up. We're going to move on to some other random anatomy. Okay, what is a meniscus? Well, a meniscus is probably best shown with our skeleton app. We've got a set of nice knees here. And knees have lots of ligaments. Okay, so you've got menisci. You have a medial and a lateral meniscus in each knee. This is your medial meniscus. It's kind of like a horseshoe-ish shaped wad of fiber cartilage that's going to have the function of protecting and securing your knee joint. Okay, that's your medial. Over here is your lateral meniscus. Okay, here's your medial on this side. Here's your lateral meniscus, and you can kind of get an idea. If I remove this bone, you can kind of see how that looks from the top. Okay, so your femur just kind of sits in there. It makes kind of a little cup and a pad that enables some cushioning and control, bonding the tibia and the femur together. So we come back over here to the next piece of anatomy. Well, let's skip down to collateral ligaments. Collateral ligaments are going to be the ligaments around your knee that secure and protect it. So you've got a lateral collateral ligament, a medial collateral ligament on the medial aspect, and this is actually your patellar ligament, so that's not a collateral ligament. Back here, you've got more. You've got that's your lateral meniscus again. Let's see here. You got your anterior cruciate, best visualized kind of from that angle. Okay, it limits anterior translation. And then back here, you've got your posterior cruciate ligament. These are different than collateral ligaments. I'm not sure if she would accept that. It kind of is, but really the big ones that you can remember are going to be lateral and medial collateral ligaments. That's technically the best answer for a collateral ligament because these ACL and PCL are cruciate ligaments, but they essentially perform the same function. The lateral collateral ligament is going to protect your knee from basically a stress going from medial to lateral, and vice versa for the medial. Anterior cruciate or posterior cruciate ligament will protect posterior translation or movement through the knee, and the ACL will do the opposite. So if we move on here to just a few clinical notes, pretty simple stuff. You've got dislocation, sprain, and arthritis, two different types of arthritis. Before we actually do that, I forgot to mention the bursa of the knee. Okay, that's in this little picture here. Really simple. Bursa, bag. When you see bursa, think bag. They're just little bags of synovial fluid that act to cushion joints in different areas. Your knee has several of them. You'll get them all, the names of them all in your gross second half of your gross class. But they're just bags of synovial fluid that act as a cushion. That's all they are. So bursa are bags. Okay. Now we're ready for these pathologies. Okay, dislocation. Everybody knows what that is. It's just completely displacing a joint. Okay, one bone is not where it's supposed to be anymore in relation to the other bone. Our specialty here is subluxation, which is a partial dislocation. But a dislocation is going to be much more dramatic and going to require some more invasive procedures to fix that. Out of our scope of practice, at least in most states. A sprain is going to be an overstretch or a tearing of ligamentous tissue, as opposed to a strain with a T is a tearing of muscular tissue. So a sprain is going to involve a ligament. And next we'll talk about rheumatoid arthritis. and wrap up with osteoarthritis. Rheumatoid arthritis is shown in red because it reminds me of inflammation, the color red, I suppose. But rheumatoid arthritis is an autoimmune inflammatory condition. So you need to know that it's autoimmune in nature. You need to know that the pathology is due to inflammation. And the inflammation takes place in the synovial membrane of the synovial joint. So if you look at this diagram here on the right, you can see our layers again. We're talking about the inner synovial membrane, and it would mostly be in that cellular layer of the synovial membrane, but you need to at least be able to put this pathology in the synovial membrane of a synovial joint. It is a condition that is usually bilateral, and it usually affects small joints in the hands and the feet, but it could be anywhere, but it's notable for being in the fingers and toes. It's bilateral because it's not a wear and tear type of pathology. It's an autoimmune thing, so it's just kind of everywhere. And it's due to different things, but it could be genetic in nature, and the age of onset is usually middle-aged, a little bit more common in women, but middle-age onset is kind of the typical time frame for this. So before we move on to osteoarthritis, just be sure that you can recall or list that rheumatoid arthritis is due to autoimmune induced inflammation in synovial joints, and specifically in the synovial membrane. And you'll get more details on this later, but essentially it causes a roughening, a thickening of that synovial membrane, which just causes more inflammation and abnormal secretions and the creation of a nasty type of tissue called pannus formation, which just further exacerbates the problem. Okay, to wrap it up, we've got osteoarthritis. Kind of happens to everybody. It's a quote-unquote wear and tear type of degeneration. That may or may not be completely true, but that seems to be the case and the most widely observed description of it. Okay, so it's called a wear and tear type of degeneration. It's going to be most common at the large weight-bearing joints, or any joint that gets used a lot, especially if there's repetitive use. If someone had an occupation where they were doing a movement all the time, it could happen there. And then any injured synovial joints. Usually this is an older age onset, and you'll have some accessory bone formation, also called osteophytes, also referred to as just sclerosis. Well, sclerosis is not an accessory bone, but in a way it is, because it's extra thick bone in bone. And on the right we've got a picture of an arthritic knee. This is the medial aspect of the knee, which is the most common spot for arthritis to occur in the knee, for osteoarthritis to occur in the knee, because most of the weight is actually transferred through the medial aspect of the knee. So what you've got here is it's a narrow joint space compared to the lateral side. Okay, there should be probably 3 times this much space, and this would be full of cartilage. Okay, that cartilage has worn away, and you've got subchondral bone rubbing on subchondral bone, and that's going to cause your body to react to that increased stress by a Wolff's Law. It's going to lay down more bone in the subchondral area, and that's called sclerosis. And then this little guy right here, you can't see it very well on this small, poor resolution image, but there's a little spiky thing right here. This is called an osteophyte, and this is really common with degenerative disc disease in the spine and degenerative joint disease, also in the spine, in the facet joints, and also throughout the body in the extremities, wherever you've got abnormal movement, abnormal motion, abnormal biomechanics. Over time, it can cause these little spiky guys to grow, and they're called osteophytes. So those are the characteristics of osteoarthritis as exemplified in a knee. And you should know that it's probably, I would expect it to hit something about large weight-bearing or high-use joints, and the old age onset. for sure know, once again, that rheumatoid is autoimmune, and it's inflammation because of a gritty synovial secretion. Okay, so that concludes topic 4. Review anything you're not real clear on. Take the time to probably draw out a synovial joint, being able to list these different layers, because it can get a little bit confusing. But remember, type A synoviocytes, A for ate, is eaten in the past tense. Make sure you know what macrophages and phagocytosis means. And then type B are the blastic builder cells. They're not making they're not making fibers, they're not making collagen fibers, but they're making a long strand of something, which is actually just sugar, hyaluronic acid. Okay, so thanks for watching, and we'll see you guys next time.